Uro Surgery Part 3 Pyenephrosis Definition Retention of infected urine and pus in the kidney Pathology The pelvic calcaeal system is transformed into multilocular cavity filled with pus and lined with necrotic renal parenchymal tissue. There is marked perinephritis with dense adhesions and fibrofatty proliferation. Secondary calculi with calculus pyenephrosis are common. Differential diagnosis similar to that of acute pyelonephritis. Etiology primary and secondary. Primary due to both infection and obstruction, as in renal calculi. Secondary due to infection of a pre-existing hydronephrosis. Complications septicemia and septic shock, renal scarring and damage, leading to renal failure. Clinical picture as pyelonephritis plus renal mass. So symptoms are loin pain, timing, worse at night, character, constant aching, and renal colic with passage of pus or stones down the ureter. Signs, general, fever, evening rise of temperature to 37.5 degrees Celsius or 38. Considerable rise may occur from retention of purulent urine. Local, swelling and pyuria. Swelling, the kidney is palpably enlarged, tender, and with limited mobility. Fluctuation cannot be elicited, usually small, but if due to infection of hydronephrosis, it's very large. Pyuria, cystitis, turbid urine and contains much pus, settles to glass bottom. Investigations, laboratory, urine analysis and culture. Radiological, abdominal ultrasound shows dilated kidney with pus inside. A plain X-ray may reveal a calculus. CT scan, more accurate in detecting stones. Treatment, urgent treatment. Antibiotics and kidney drainage by inserting a large percutaneous nephrostomy tube or ureteric caster. Any cause of obstruction as a stone or stricture is corrected. Nephrectomy. Indications, advanced cases with atrophic parenchyma and total renal functional loss as detected by radioisotopes renal scan. Prerequisite, opposite kidney is normal. Preliminary nephrostomy may be done first. Perinephric abscess. Definition, suppuration of perinephric fat and fascia. Incidence, a perinephric abscess usually affects adults, more on the right side. Pathology, the infecting organisms are staphylococci, less commonly, streptococci and E. coli. Pus collects between kidney and perinephric fascia, extending downwards into pelvis along the course of the ureter, or may burst through perinephric fascia, leading to reaching to the loin. Complications of neglected abscess, septicemia and septic shock. Definition of the perinephric abscess, suppuration of a perinephric fat and fascia. Etiology. Okay, I have mentioned definition. Etiology, primary perinephric abscess, rare, blood-borne from a distant septic focus as a boil or carbuncle. Secondary perinephric abscess, which is more frequent due to extension of the infection from the kidney or neighboring structure, such as spine, pleura, or pelvic organs. Clinical picture, symptoms, loin pain, which increases by movement, respiration, and coughing. Signs, general, hectic fever. Local, loin fullness, tenderness, and rigidity. Swelling is ill-defined and doesn't move with respiration. Edema and skin redness if the abscess extends superficially. Slight eversion and flexion of hip joint from psoas muscle spasm. Investigations, lab and radiological. Lab, urine analysis, usually sterile. CBC, polymorphonuclear leukocytosis. Radiological, ultrasound or CT scan, diagnostic, pus around the kidney. Plain X-ray shows scoliosis with the concavity towards the abscess side, obliteration of the psoas shadow, elevation and fixation of the diaphragm. Treatment, for any abscess, drainage of pus through lumbar incision under general anesthesia. All pockets are thoroughly opened, a wide drain is inserted, antibiotics are complementary. Cystitis, etiology and pathology. Causative organism, E. coli, the commonest. Others, Proteus, Streptococcus, and Pseudomonas aeruginosa. Predisposing factors, incomplete bladder emptying, accumulation of residual urine such as prostatic obstruction, urethral stricture, and neurogenic bladder, lowered general resistance such as diabetes and urinary instrumentation, calculi, foreign bodies, and bladder neoplasms. Routes of infection, ascending, descending, and direct. Ascending, commonest from the urethra, prostate, and vulva, or during instrumentation. Descending from the kidney, direct through a vesicovaginal or vesicointestinal fistula. Clinical picture, symptoms and signs. Symptoms, increased frequency, diurnal and nocturnal. Main symptom, suprapubic and perineal pain, timing at the end of micturition, referral to the glans penis or labia majora. Signs: pyrexia, rarely in acute cases and it seldomly reaches 38 degrees Celsius. Tenderness over bladder on abdominal, rectal, or vaginal examination. Pyuria, cloudy urine and feathery deposit, which may appear on standing. Hematuria, terminal hematuria, the last few drops of urine are blood-stained. In severe cases, whole specimen may be blood-stained. Investigations: lab examination of the urine, midstream specimen is sent for analysis and culture and sensitivity. Instrumental cytoscopy, contraindicated in acute stage. In chronic cases, it reveals the precise pathological lesions and local predisposing causes in bladder, urethra, or prostate as bladder ulcer. Plain X-ray, ultrasound, IVU treatment follows the previously mentioned general principles. Prostatitis, acute prostatitis, etiology, causative organisms are Escherichia coli, most common, others Staphylococci and Aureus and albus, Streptococcus faecalis, Neisseria gonorrhea or chlamydia. Route of infection from the posterior urethra. It may easily be diagnosed as having influenza. Complications: spread of infection to the epididymis and testis. Treatment must be vigorously treated and prolonged to eradicate infection and avoid recurrent attacks. Clinical picture. Symptoms: we have general, local. General overshadows the local. The patient feels ill, shivers, aches all over, especially in the back. The temperature may be up to 39 degrees Celsius. Local: pain on micturition. Urine contains threads in the initial voided sample. Cultured. Perineal heaviness, rectal irritation, pain on defecation. Frequency: when infection involves the bladder. Signs: DRE, tender prostate. One lobe may be swollen more and seminal vesicles are involved. A frankly fluctuant abscess is uncommon. Treatment: prolonged treatment with antibiotic which penetrates the prostate, such as trimethoprim or fluoroquinolone. We have prostatic abscess. Clinical picture. Symptoms: rising steeply temperature with rigors masked by antibiotics. Severe unremitting perineal and rectal pain with occasional tenesmus confused with anorectal abscess. Urine retention. Best treatment is suprapubic catheterization. Signs: DRE, prostate is enlarged, hot, extremely tender and fluctuant. Treatment: drainage without delay by transurethral evacuation or transperineal aspiration and drainage. Empiric antibiotics till results of pending culture with fluoroquinolone such as ciprofloxacin. Chronic prostatitis, etiology: inadequately treated acute prostatitis. The causative organism: chlamydia. Clinical picture. Symptoms of posterior urethritis: prostatic pain and perigenital pain accompanied with intermittent fever. Signs: DRE, normal or may show soft, booby and tender prostate. The diagnosis of chronic prostatitis is difficult. In many cases, all investigations are normal. Diagnosis: lab. The 3-glass urine test is valuable if first glass was initial voided sample. Urine containing prostatic threads, prostatitis is present. Prostatic fluid examination obtained after prostatic massage, showing pus cells and sometimes bacteria. Instrumental urethroscopy. Inflammation of the prostatic urethra and pus may be seen exuding from the prostatic ducts. Treatment: antibiotics for a long period of time, probably a few months. Trimethoprim and fluoroquinolones penetrate into prostate. If chlamydia is suspected, doxycycline is a treatment of choice. Urethritis, gonococcal urethritis. Clinical picture. Incubation period from 3 to 10 days. It may be asymptomatic in males. Urethral itching, urethral discharge, and dysuria. Without treatment, urethritis will stay from 3 to 7 weeks. 95% of men become asymptomatic after 3 months. Spreading of infection to prostate leading to prostatitis, and epididymis leading to epididymo-orchitis. Gonorrhea is a sexually transmitted disease. Neisseria gonorrhea are gram-negative diplococci located within neutrophils. Common site of infection is urethra. Concurrent infections with chlamydia and others are also common. Investigations: gram-stain smear, the usual method. Positive if gram-negative diplococci are seen within the polymorphonuclear leukocytes. Alternative diagnostic methods are based on detection of gonococcal enzymes, antigens, DNA, and liposaccharides. Complications: tensosynovitis, arthritis, prostatitis, epididymitis, periurethritis, abscess formation leading to urethral fibrosis and urethral stricture. Then treatment: antibiotic treatment. Treatment of the sexual partner is mandatory. Sexual intercourse should be avoided until cure. And then differential diagnosis: non-gonococcal urethritis, discharge is scant and clear. Specific infection, urinary bilharziasis, schistosomiasis, incidence affecting adolescents and adults between the age of 10 and 30, males suffering more than females 4-1. The majority has history of exposure to water canals, especially small streams such as farmers and fishermen. Non-gonococcal urethritis, incidence 50% of urethritis cases, etiology, mainly chlamydia, trachomatis, clinical features, incubation period 7 to 21 days, symptoms, dysuria, mild whitish or clear scanty urethral discharge, may be absent and the patient only complains of urethral itching, asymptomatic in context of women with known cervical chlamydial infection, treatment, tetracycline for both the patient and sexual partner. Again, to urinary bilharziasis, etiology, the cause of organism, schistosoma hematobium, 96%, while schistosoma mansoni, 4%. Then the worms migrate from the liver to the mesenteric veins, anastomotic channels between hemorrhoidal and vesical prostatic plexus, leading to the urinary bladder. Pathology, site, urinary bladder, the commonest, gross picture, patchy hyperemia over the trigone, and bilharzia sandy patches, aggregations of calcified dead ova in the submucosa, appears through mucosa-like sand underwater. They form a barrier to the passage of ova, so normal urine doesn't mean a cure of the disease. Bilharzial tubercles, bilharzial nodules, bodies which may have a pseudoglandular or cystic appearance, cystitis glandularis and cystitis cystica, bilharzial papillomata, bilharzial granulomata, bilharzial granulation tissue submucous masses, smooth tumor-like swellings projecting into the bladder, and finally bilharzial ulcers. Complications, secondary bacterial infection which is common, acute or chronic cystitis, stasis leading to stones, changing pH and deposition of debris and blood, infiltration and fibrosis of intramural ureter leading to ureteric obstruction, usually bilateral progressive dilatation of kidneys and ureters, fibrosis, bladder neck obstruction, hypertrophy and bladder trabeculation leading to dilatation and incomplete emptying, residual urine, malignancy starting in patches of leukoplakia, cystitis cystica, cystitis glandularis, ulcers and papillomata, rarely precancerous. The most important predisposing factor, alkaline sepsis with ammoniacal decomposition. Clinical picture, symptoms, swimmers or bather's itch due to cercaria skin penetration. After 4 to 12 weeks, fever, urticaria, and asthma may pass unnoticed. Within 6 months, ova invade the bladder, leading to hematuria, cardinal symptom, slight few drops and terminal, pain, character, urethral burning, increasing in cases of ulceration, stone formation, or malignancy. Frequency causes trigone congestion, but later it follows secondary cystitis. Investigations, laboratory, urine examination in acute congestive stage. Urine looks smoky and contains living bilharzial ova and RBCs. When secondary infection occurs, becomes alkaline and turbid with blood pus phosphates, epithelial debris and dead ova. Radiological, plain X-ray, bilharzial calcification of bladder, terminal ureters, seminal vesicles, honeycomb pattern, and calcified papilloma or calculi. IVU shows strictures of the ureters, hydronephrosis or bladder neck obstruction. Instrumental cystoscopy, bilharzial lesions, and take biopsy. Treatment, antibilharzial drugs. If secondary cystitis is present, urinary antiseptics. Surgical treatments depending on the individual lesion, cystitis cystica, cystitis glandularis, and bilharzial papillomata, only if bulky and cause obstruction, cystoscopic fulgration or excision biopsy. Superficial bladder ulcers, cystoscopic excision. For severe cases and for deep ulcers, partial cystectomy. Bladder neck obstruction, cystoscopic incision or resection. Lower ureteric stricture, ureteroscopic balloon dilatation or uretrovesical implantation. Obstructive uropathy, general principles, etiology, renal causes, renal stones, congenital idiopathic pelviureteric junction obstruction or the PUJU. Aberrant renal vessels, renal pelvic tumors. Ureteric causes in the lumen, stones in the wall, ureteric stricture, bilharzial, TB, iatrogenic tumors outside the lumen, compression, idiopathic retroperitoneal fibrosis or infiltration by carcinoma of cervix, colon or rectum. Urinary bladder causes, tumors involving uretrovesical junction, neurogenic bladder dysfunction. Bladder neck causes, congenital bladder neck obstruction, bilharzial neck obstruction. Prostate causes, benign prostatic hyperplasia, carcinoma of the prostate. Urethral causes, congenital meatal congenital meatal stenosis and posterior urethral valves, stricture of the urethra. Pathological changes all occur above the obstruction urethra, increased hydrostatic pressure leading to urethral dilatation, urinary bladder early in the compensated phase, increased urethral resistance, bladder muscle layer hypertrophy, the bladder wall becomes trabeculated, mucosa protrudes between muscle fibers leading to saccules. When mucosa bulges outside the bladder wall, it leads to diverticula. Later, with unrelieved obstruction, bladder dilates and its walls thin out, leading to atony, urine retention, ureter, early, muscular hypertrophy of the wall, later, atony, hydroureter, dilated, elongated, and tortuous. Kidney, we have morphological changes. Pressure in pelvic calcaeous system increases, leading to hydronephrosis. The first to suffer are the calces, concave, cupping, normal, flat-rounded, clubbing, and then they become ballooned. The increasing intrapelvic pressure leading to compression, renal parenchyma against the renal capsule, ischemic atrophy, thinning out. Later, complete kidney destruction. They become thin-walled sac with clear fluid or pus if infected. Functional changes. Intrapelvic pressure continues to rise until it overcomes the GF pressure, glomerular filtration pressure, leading to a stopping of the urine formation. The contralateral normal kidney undergoes compensatory hypertrophy in order to maintain an overall normal renal function. In neglected bilateral obstruction, renal failure occurs. With relieving the obstruction, early treatment, major morphological and functional improvement occur. Delayed treatment, some degree of irreversible renal damage. Factors affecting changes following obstruction, the level, the degree, the duration of obstruction, and development of infection on top of the obstruction. Level of obstruction, obstructive lesion at or below bladder neck, bilateral effect. Lesion in ureter or the PUG affects only one kidney. Degree of obstruction, severe obstruction leads to more damage. Duration of obstruction, long-standing, partial, or intermittent obstruction leading to marked dilatation, while acute obstruction leads to mild dilatation but rapid functional deterioration. Development of infection leads to serious deterioration. Complications, stasis leads to infection, leads to further faster functional kidney deterioration, stone formation, renal insufficiency, and finally failure in bilateral cases. Normally, the pressure within the renal pelvis is close to zero. Obstructive urinary conditions which require urgent relief are acute urine retention, calcular anuria, accidental ligation of both ureters at surgery, infection on top of obstruction, accelerated functional deterioration, and sepsemia. Hydronephrosis, definition, chronic aseptic dilatation of the renal pelvis and calces due to partial or intermittent obstruction of the urinary tract, unilateral or bilateral. Etiology, all causes of chronic obstructive uropathy, vesico-ureteric reflux, pregnancy, hydronephrosis especially on the right side, temporary and subsides within 2 to 12 weeks after delivery onset, first few weeks, and reaches maximum within 5th and 6th month. Cause, we have high progesterone level leads to ureteric musculature atony, and the fetal head may press on both ureters. Differential diagnosis of palpable hydronephrosis, polycystic kidney, and hypernephroma. Clinical picture, pain, character, slight dull aching or sense of discomfort in the loin, if large, swelling, cystic swelling which fills the renal angle, and if advanced and bilateral manifestations of renal failure. Investigations, lab, urine analysis, RBCs, crystals, and pus cells. Radiological, ultrasound examination detects renal size, renal cortex thickness, and the cause. Stones, IVU will show the following: dilatation of the renal pelvis. It becomes biconvex. Pelvic-ureteric junction is distorted and raised upwards. Loss of cupping and clubbing, then ballooning of the minor calces. The major calces are also dilated. Delayed contrast excretion and medium concentration is below normal. In advanced cases, no secretion occurs. Ascending or retrograde pylography to confirm diagnosis and to see the cause. Treatment, removing the cause of obstruction, leading to recovery of the kidney. Nephrectomy, avoided as possible. However, it's justified in the following cases, such as the kidney is non-functioning with infusion urography, sonography showing very thin parenchyma, renal scan showing zero function, and finally, the opposite kidney is normal. Percutaneous nephrostomy indications, compromised cases with bad other kidney, Duration till obstruction is treated. Pyroplasty, plastic operation to reduce the pelvis size. Indications: advanced cases of pelvic hydronephrosis. Advantage: provide adequate drainage of the lowest part of the pelvis. Structure of the ureter. Etiology: congenital, traumatic, inflammatory, long-standing stone, and neoplastic. Neoplastic, such as carcinoma of the ureter. Invasion of ureter by carcinoma of uterus, colon, and rectum. Long-standing stone. Inflammatory, bilharzia, affecting intramural and lower part of the ureter, and less commonly opposite third lumbar vertebrae, may be bilateral. Tuberculous, affecting whole ureter, usually multiple and bilateral. Traumatic, following open or closed surgery injuries, particularly operative or instrumental. Congenital, at the puju or at uretero-vesical junction. Pinhole meatus. In Egypt, bilateral hydronephrosis is commonly due to bilateral bilharzia ureteric stricture, leading to chronic renal failure. Clinical picture: renal aching pain due to renal pelvis distension, progressive hydronephrosis, recurrent attacks of pyelonephritis, chronic renal failure in bilateral bilharzial stricture. Investigations: lab, blood, urea, serum creatinine and serum electrolytes. Radiological: ultrasound, hydronephrosis. IVU determines the structure site and degree of functional capacity of the kidneys. Retrograde and antegrade pyelography. Treatment: mainly surgical. Structure of the upper 2/3, excision and end-to-end anastomosis, while the structure of the lower third, uretero-vesical implantation. Urinary stones. Etiology and predisposing factors. Urine stasis, excess normal constituents in urine, presence of abnormal constituents in urine. Urine stasis, as in benign prostatic hyperplasia and strictures, allowing stones to form. Stasis also predisposes to infection. Excess normal constituents in urine. Low urine volume, raising its concentration. Excess urinary excretion of calcium, hyperparathyroidism, idiopathic, and prolonged immobilization. Excess urinary excretion of uric acid, chemotherapy, gout, purine-rich foods such as meat, liver, and kidney. Excess urinary excretion of oxalates, idiopathic hyperoxaluria. Excess dietary intake of strawberries, green leafy vegetables, and tea. Loss of terminal ileum by resection or Crohn's disease. Presence of abnormal constituents in urine, infection, foreign bodies, vitamin A deficiency, and cystinuria. Cystinuria, cystin stone formation. Vitamin A deficiency, rare cause. Causes of hyperkeratosis of urothelium. Epithelial debris acts as nidus for stone formation. Foreign bodies acting as nidus for stone formation, such as non-absorbable sutures, ureteric stents, or catheters. Infection, producing epithelial desquamation upon which calculi deposit. Infection with urea-splitting organelles. Urine alkalization, favoring formation of phosphate stones. Incidence, common, affecting 10 to 20% of population at some stage of life. Males are more affected than females, occurring mainly in middle-aged persons, but no age is immune. 2/3 of patients have one or more recurrences within following 8 years. Normal urine flow expels crystals before they coalesce and grow to form stones. Composition of urinary calculi. Calcium calculi, 75%. Majority of urinary stones, whether calcium oxalate, calcium phosphate, or a mixture of both. Calcium oxalate calculi, the most common, radio-opaque, surface, hard, and spiky. Injure epithelium, leading to bleeding, dark brown or black color. Calcium phosphate stones, radio-opaque, smooth surface, yellowish-white, and they grow in alkaline media and they can attain a large size, leading to staghorn calculus, filling renal pelvis and calyces. Ammonium magnesium phosphate, struvite calculi, 15%. They are radio-opaque, friable, amorphous, and have smooth surface with yellowish-white color. Form in foul-decomposing alkaline urine and grow very rapidly, often filling the renal pelvis and calyces. Uric acid calculi, 7 to 9%, radiolucent, not showing on plain films, hard, smooth, and golden yellow. Diagnosis: ultrasound and CT, excretory urograms, leading to filling defect. Cystine or cystin stones, 1 to 3%, xanthine stones, very rare. Clinical picture: renal and ureteric calculi, asymptomatic in staghorn stone or a tiny stone in calyx. Symptoms when a stone gets impacted, leading to obstruction. Common sites for stone impaction are pelviureteric junction, pelvic brim as ureter crosses iliac artery, and uretero-vesical junction. Pain, the main symptom, renal pelvic stone. The pain is fixed dull aching, site in renal angle, radiation to the back or hypochondrium anteriorly, increased by movement. Ureteric stone, as a stone moves along the ureter, ureteric colic in the upper third, colicky pain in the loin, radiating to groin or testicles or labia majora, restlessness due to inability to obtain relief irrespective of position. In medial 1/3, iliac pain, simulating appendicitis. In lower end, pain at the end of micturition, refer to the tip of penis. Associated symptoms, frequency and strangury. Nausea and vomiting during attack of pain due to irritation of the celiac ganglion. Abdominal distension, hematuria, gross or microscopic due to mucosal injury during stone migration. Fever, rare unless there is UTI. Urinary bladder calculi, suprapubic bladder pain, refer to tip of penis or labia majora or to perineum, more prominent at daytime during micturition. The pain decreases during sleep or in recombinant position as stone moves away from the trigone. Then frequency of micturition causes irritation of the bladder mucosa and trigone. Timing at first only during daytime diurnal, but if cystitis develops, it becomes diurnal and nocturnal. Difficult micturition and interrupted urine stream during micturition. Acute urine retention causes obstruction of bladder neck by a stone. Terminal hematuria, few drops by the end of micturition from abrasions of the trigone. Urethral calculi, severe urethral pain, difficulty and interruption of micturition stream, retention of urine, and if a stone is in the anterior urethra, it can be palpated. Complications, obstruction, infection, hematuria, deterioration of renal function, and metaplasia of urinary epithelium. Metaplasia of urinary epithelium, the stone leads to friction, leading to chronic irritation of transitional epithelium in the pelvis or urinary bladder, leading to squamous metaplasia and squamous cell carcinoma. Deterioration of renal function, whether by obstruction or infection, and renal failure occurs if it's in the only functioning kidney. Infection, as stasis invites infection. Obstruction, ureteric stones, hydroureter hydronephrosis, pelviureteric junction stone, hydronephrosis at the neck of calyx, calcaeal dilatation, hydrocalyx. Investigations, lab, urine analysis, hematuria in at least 90%, microscopic or crystals of the same type that are forming the stone. Radiological, CT, the first choice. Without contrast, it visualizes the smallest stones. Images can be reconstructed with computer software to produce high-quality images of the whole urinary tract. It visualizes both radio-opaque and radiolucent stones. Plain, UT, urinary tract X-ray, calculi show in 90% in descending order of density. Calcium phosphate is the densest, followed by calcium oxalate, struvite, and cystine. Uric acid stones are radiolucent. Ultrasonography advantages: sample visualizes the kidney and the degree of back pressure changes. Diagnoses bladder stones in radiolucent calculi. Disadvantages: not reliable to visualize ureteric calculi. IVU, intravenous urography, mandatory in all cases. Advantages: confirming presence of stone and determines its position. Detects radiolucent calculi appear as filling defects, showing the cause of stone structure or benign prostatic hyperplasia. Gives idea about kidneys function and back pressure effects. Helps in choosing proper line of treatment for a particular stone. Differential diagnosis of radio-opaque shadow in plain X-ray. Urinary stones, gallbladder stones in only 15%, usually multiple, faceted, with signet ring appearance on right side, lateral view, anterior to vertebral bodies, near anterior abdominal wall. If renal stone, it lie overlying the vertebral body posteriorly. Pelvic, phlebolith, a small spot of calcification in the pelvic vein. Simulates ureteric stones on IVU. They lie outside the ureter. Calcified mesenteric lymph nodes, multiple, mottled, and take the line of the root of mesentery from right iliac fossa to the left upper abdomen. Nephrocalcinosis, calcified renal tumors, fractured tip of transverse process of a lumbar vertebra, calcified costal cartilage, adrenal gland calcifications, and appendicolith, appendix stone, and foreign bodies in the intestine. Remember the course of ureter to be able to suspect or exclude an opaque shadow as a ureteric stone. It starts opposite the tip of transverse process of L1 or L2 vertebrae and then passes down along the tips of transverse processes of the following lumbar vertebrae. Then it crosses the pelvic brim opposite to the sacroiliac joint to enter the true pelvis. At the level of ischial spine, it turns medially to enter the bladder. Treatment of renal colic. Most cases are treated as outpatients. Hospitalization for patients with severe colic and with persistent vomiting. Parenteral analgesics, NSAIDs as entomycin or diclofenac. Narcotic analgesics as opiates in resistant cases. Antiemetics, metoclopramide. IV fluids are given according to normal patient's requirements if vomiting is persistent. Forcing excess fluids during the attack, flushing out the stone, but if not, it increases the pressure in an obstructed system, increasing pain. Antibiotics if UTI is suspected. And this concludes our part for the urosurgery for today.